Welcome back to the Deep Dive. Today, we're zeroing in on a really important medication, Clozapine.
That's right. It's absolutely critical for a specific group of patients, those with treatment-resistant schizophrenia.
And our discussion today, it's based on a medical text aimed at clinicians, giving us the core information.
Exactly. We're hoping this is especially useful for, pharmacy students tuning in, and also practicing pharmacists who might want a refresher or consolidation of their knowledge.
Perfect. So let's dive right in. Where does Clozapine actually fit? What's its main job?
Okay, so its primary indication, the main reason we use it, is for treatment-resistant schizophrenia.
Treatment-resistant?
Yeah.
What does that mean in practice?
It means the patient has already tried at least 2 other antipsychotic medications.
2 different ones?
Yes, 2 different ones, and each for a decent duration, typically at least 6 weeks. If those haven't worked well enough, then Clozapine comes into play. It's often considered first line for this specific situation.
And it helps with more than just the hallucinations or delusions.
Absolutely. That's one of its strengths. It tackles the positive symptoms, yes, but also the negative symptoms, things like emotional flatness, lack of motivation.
Which can be really hard to treat.
Extremely hard, and cognitive symptoms too. Plus, a really key point from the text is its proven ability to reduce suicidal behavior in these patients, which is quite unique among antipsychotics.
That's significant. Now, I know Clozapine has a bit of a history, doesn't it?
It certainly does. Synthesized way back in 1958. And interestingly, even early on, they noticed it didn't seem to cause those movement side effects, the extrapyramidal symptoms or EPS, that were common with older drugs.
But it wasn't smooth sailing.
No, not at all. It hit a major roadblock in 1975. It had to be withdrawn because of cases of granulocytosis,
Which is?
a very dangerous drop in white blood cells, specifically neutrophils. It can be fatal.
Wow. So how did it come back?
It was reintroduced around 1991, but with a huge condition attached. Mandatory, strict blood monitoring. Regular blood tests became non-negotiable.
That history really puts the monitoring requirements into perspective.
It absolutely does. It underscores why we take it so seriously.
So, pharmacologically, what makes it different? Why does it work when others don't? And why fewer of those movement issues?
Well, a key thing the text points out is its relatively low affinity for the dopamine D2 receptor. That's the main target for many older antipsychotics. And hitting it hard is linked to EPS.
Okay, so less D2 action means fewer movement side effects.
Generally, yes. But the flip side, and probably why it works so well for treatment resistance, is its high affinity for a whole bunch of other receptors.
Like which ones?
We're talking D4 receptors, various serotonin receptors like 5-HT2A and 5-HT1C, plus cholinergic and adrenergic receptors. It's a much broader spectrum of action.
And that complex profile is thought to be why it helps with those negative and cognitive symptoms, and maybe the suicide risk reduction.
That's the thinking, yes. Hitting multiple neurotransmitter systems seems to give it that edge, especially for patients who haven't responded to drugs that are more selective for just D2.
Makes sense. Let's talk practicalities then. Dosing. How do you actually use it?
Right. So the typical target dose range, according to the text, is generally between 300 milligrams per day and 900 milligrams per day. Sometimes even higher, but that's the usual window.
And you don't just start someone on 300 milligrams.
Oh, absolutely not. The rule is start low, go slow. You begin with a very low dose, maybe 12.5 or 25 milligrams, and titrate upwards gradually.
Why so cautious?
Mainly to minimize side effects, particularly things like sedation and orthostatic hypertension, that dizziness when standing up. It gives the body time to adapt.
And how long before you know if it's really working?
It can take time. The text suggests around 8 weeks to really gauge the therapeutic effect, sometimes longer. Patience is key.
What about blood levels? Do we monitor those?
Yes, plasma concentration monitoring is valuable. The target range mentioned is 350 to 600 micrograms per liter. In Canada, the units are different, 20/70 to 1835 nanomoles per liter.
And how do you measure that accurately?
You need a trough level. That means drawing the blood sample about 12 hours after the last dose, right before the next one is due. And you should wait until the patient's been on a stable dose for at least 3 days.
Okay. And there's something crucial if treatment gets interrupted, right?
Yes, critically important. If a patient misses their Clozapine for 48 hours or more, just 2 days, you must restart them at the initial low dose and titrate up again slowly.
Why is that?
Because restarting at a higher dose after even a short break carries a significant risk of serious adverse effects, like seizures or cardiovascular issues. The body loses its tolerance quickly.
Right. That's a vital safety point.
Right.
Now, back to that mandatory monitoring, especially the blood counts because of the granulocytosis risk. How does that work?
It's very structured, especially in the first 6 months, which is the highest risk period. The text describes a color-coded system based on the absolute neutrophil count, the ANC.
Okay, walk us through the colors.
Sure. Green means go. ANC is 2.0 by 10 odor per liter or higher. You continue treatment and standard monitoring, which is usually weekly for the first 6 months, then maybe every 2 weeks for the next 6, then monthly.
And yellow.
Yellow means caution. The ANC is between 1.5 and just under 2.0. You typically increase monitoring frequency maybe to twice a week and watch very closely. You don't necessarily stop, but you're on alert.
And red.
Red means stop. ANC is below 1.5 by 10 over per liter. Clozapine must be discontinued immediately due to the high risk of severe neutropenia or agranulocytosis.
That's very clear. But it's not just blood counts, is it? There's metabolic monitoring too.
Correct. Clozapine has significant metabolic risks, weight gain potentially leading to diabetes and dyslipidemia, so issues with cholesterol and triglycerides.
So what needs checking there?
Weight and waist circumference should be checked frequently, especially early on. The text suggests every 1 to 2 weeks for the first couple of months. Also, regular monitoring of blood glucose and lipids according to guidelines.
And anything else? Cardiac issues.
Yes, the text briefly mentions the need to be vigilant for rare but serious cardiac effects, like myocarditis, inflammation of the heart muscle, and cardiomyopathy. Usually manifests early in treatment if it happens.
There's a lot to keep track of. What about other side effects, the more common ones?
Yeah, besides the serious ones we've covered, common issues include sedation. That's another reason for the slow titration.
Makes sense.
Hypersalivation or excessive drooling can be quite bothersome for patients. Constipation is also very common.
How do you manage the constipation?
The text recommends things like osmotic laxatives. Importantly, it advises against bulk-forming laxatives, as they can sometimes worsen the problem in the context of decreased gut motility.
Good tip. Anything else common?
Orthostatic hypotension, that dizziness on standing, can happen, especially during titration. And seizures can occur, particularly at higher doses or with rapid dose increases.
Okay, so common ones like sedation, drooling, constipation, dizziness, and rarer serious ones like the blood counts, seizures, heart issues, and also enuresis or bedwetting is mentioned too.
Exactly. It's a balance, always weighing the significant benefits against these potential risks and managing them proactively.
What about drug interactions? Anything pharmacists really need to flag?
Oh, absolutely. The big one highlighted in the text is smoking. Cigarette smoke specifically?
No, the nicotine itself.
Not primarily the nicotine, no. It's the other components in the smoke, the polycyclic aromatic hydrocarbons. They strongly induce the liver enzyme CYP1A2.
And CYP1A2 metabolizes clozapine.
Yes, it's a major pathway. So smokers often need higher doses of clozapine to achieve therapeutic levels because they break it down faster.
So what happens if a patient on clozapine stops smoking?
Their clozapine levels can rise significantly, sometimes doubling or more, because that enzyme induction stops. This increases the risk of dose-related side effects, even toxicity. It requires careful monitoring and likely dose reduction.
Can they use nicotine replacement like patches or gum?
Yes, the text mentions NRT is okay because it doesn't induce CYP1A2 the way smoke does. But you still need to monitor closely when smoking habits change regardless.
Any other key interactions?
Well, yeah, caution is needed with other meds. Benzodiazepines, for example, can increase sedation and respiratory depression risk. Some anticonvulsants can affect clozapine levels or have additive side effects. Antidepressants, too, always needs a thorough medication review.
Right. Now, what if someone is on clozapine, but they're still not getting the full benefit? Are there ways to boost its effect?
The text touches on this, yeah. Sometimes clinicians consider adding another medication, an intensification strategy.
Like what?
Maybe adding another antipsychotic, like aripiprazole is one example mentioned. Or sometimes an antidepressant, like mirtazapine, might be considered, perhaps if there are residual negative symptoms or mood issues.
Is there strong evidence for doing that?
Well, the text is quite clear that the evidence for these augmentation strategies is actually pretty limited. It's not a standard go-to approach.
So it needs careful thought.
Definitely. It has to be a very careful risk-benefit assessment for that specific patient. Adding more meds means potentially more side effects and interactions. It's usually reserved for cases where clozapine alone, even at optimal doses and levels, isn't quite enough.
Okay, that's a really comprehensive overview. So just to kind of wrap up the key takeaways from this deep dive.
Sure. Clozapine really holds a unique and vital place for treatment-resistant schizophrenia. It offers benefits beyond positive symptoms, which is huge, including reducing suicide risk.
but it comes with significant responsibilities.
Absolutely. That mandatory meticulous monitoring, especially hematologic, but also metabolic and cardiac awareness, is non-negotiable for safety.
And understanding the dosing, starting low, going slow, managing side effects, and being super vigilant about interactions, especially smoking. It's all crucial.
Exactly. It requires commitment from the clinical team and the patient, but the potential benefits for the right patient group can be life-changing.
It really sounds like it. So thinking ahead, based on everything we've discussed, well, it makes you wonder, doesn't it? With all these complexities, what's next? Are researchers looking at ways to make clozapine therapy even better, maybe more tailored?
That's a great point. Could personalized medicine play a bigger role in the future? Maybe predicting who will respond best or who's most at risk for certain side effects, allowing us to optimize its use even further for this challenging condition.
Something to think about. Definitely food for thought as research continues.